Greetings of the day. Welcome back. In this video, we shall discuss about serotonin syndrome. Serotonin syndrome is potentially life-threatening adverse drug reaction to serotonergic medications. It can be produced by any drug or more commonly by any combination of drugs that increase central serotonin neurotransmissions. So, antidepressants are drug class most commonly associated with serotonin syndrome. Serotonin syndrome is characterized by a combination of alteration in the cognition and behavior, autonomic nervous system function, and also neuromuscular symptoms. So, the degree of the abnormality in any one area is highly variable. The stimulation of specific post synaptic serotonin receptor is required for full expression of this syndrome, primarily by serotonin 5-HT1A, 5-HT2A receptors, but other receptor subtypes may contribute too. Drugs that block postsynaptic serotonin receptors are incapable of inducing this syndrome and are often used as a form of treatment. So the various drugs are most commonly, you can see here there is a long list of antidepressants starting from MAO inhibitors like phenelzine, prenylcypromine, uh, pargilene, rasagiline, selegiline, SSRIs like fluoxetine, sertraline, paroxetine, fluoxamine, citalopram, and escitalopram, SNRIs like venlafaxine, desvenlafaxine, and duloxetine, cyclic antidepressants such as amitriptyline, desipramine, doxepin, imipramine, etc., atypical antidepressants such as trazodone, bupropion, and other agents have a potency to cause like amantadine, amphetamines, codeine, dextromethorphan, lysergic acid, tramadol, and also reserpine. Here you have to see the linezolid is an antibiotic, and dextromethorphan is a normal commonly used syrup for like an antitussive. And pentazocin and also metoclopramide antiemetic and also like LSD. So many drugs can cause serotonin syndrome. Coming to the clinical feature, the triad of cognitive, autonomic, and neuromuscular effects is classic feature of the serotonin syndrome. The vast majority of serotonin syndrome cases occur in patients taking serotonergic drugs at therapeutic dosages, but approximately 10% of cases develop after overdose of serotonergic medication. Serotonin syndrome usually occurs within 2 to 24 hours after dosage of serotonin agonist. So, serotonin agonist and also the importance of serotonin syndrome in emergency practice is twofold. First, the diagnosis of serotonin is very challenging because of its non-specific symptomatology, and also mild cases of serotonin syndrome frequently are misinterpreted as other psychiatric and medical disorders, and severe cases are often misdiagnosed as neuroleptic malignant syndrome. So, because the two disorders share some features such as hypertension, tachycardia, tachypnea, fever, hypersalivation, diaphoresis. So, without proper recognition of patients at risk for serotonin syndrome, one may inadvertently precipitate serotonin syndrome by administering serotonergic agents. Okay, so to prevent iatrogenic prescription of serotonin syndrome, precipitation, sorry, to prevent iatrogenic precipitation of the serotonin syndrome, use drug by database and other resources to evaluate for potential drug interactions. Okay, this we will look after the clinical features of the serotonin syndrome. So you can see there are two major and minor. In cognitive aspect, there can be an altered level of consciousness or agitation, and in minor, there can be insomnia, restlessness, anxiety. In case of autonomic disturbances, the major manifestation will be hyperthermia and diaphoresis. And in minor, there can be tachycardia, tachypnea, hypertension or hypotension, mydriasis. In case of neuromuscular symptoms, major manifestation will be muscle rigidity, hyperreflexia, myoclonus, tremor. And in case of minor, there will be akathisia in coordination. So the severity pattern of the serotonin syndrome can be seen here. Mild manifestations include mild agitation, mild fever, tremor, myoclonus, hyperreflexia, diaphoresis, mydriasis, elevated BP, and heart rate. And in moderate, there will be marked agitation, hyperthermia more than 40 degrees Celsius, myoclonus, hyperreflexia, ocular clonus, increased bubble sounds. In case of severe, there will be hyperthermia more than 41.1 degrees centigrade, delirium, marked muscle rigidity, and marked swings in the blood pressure and heart rate. So these are the severity of the manifestations of the serotonin syndrome. So the associated with are like alternative status and increased melatonin, right? So myoclonus is common finding in the serotonin and is important distinguishing feature because myoclonus is rarely seen in other conditions. Muscle rigidity, when present, is especially prominent in the lower extremities, and which serves as another valuable clinical marker for serotonin syndrome. Patient with ataxia should be examined carefully for lower extremity hypertonia, and unilateral muscle rigidity and focal neurological deficits are not expected. Seizures are always generalized and usually short-lived. Hyperthermia is usually of moderate severity, and temperature more than 41 degrees centigrade has been reported and are a marker of poor prognosis. Hypertension is twice as common as hypotension and is associated with a more favorable prognosis. Um, so we will look after the differences between the serotonin syndrome and neuroleptic manager syndrome and anticholinergic. So here you can see precipitating factor in case precipitating event in case of serotonin syndrome is addition of serotonergic agent. In case of NMS, it's addition of dopamine antagonist with or with withdrawal of from dopamine agonist. In case of anticholinergic, there will be addition of anticholinergic agent. Okay. So in case of onset, it is usually 2 to 24 hours. This can be from days to weeks. This is within 1 to 2 hours. Distinguishing feature is myoclonus and tremor and also hyperreflexia. In case of malignant syndrome, there will neuroleptic malignant, there will be bradyreflexia or sluggish reflex response and bradykinesia, motor slowing or psychomotor retardation, and lead pipe rigidity may be seen. In case of anticholinergic toxicity, there will be dry skin and mucous membrane, and dry skin and dry mucous membranes, and normal muscle tone and reflexes will be seen. Okay, coming to the treatment part, there are no confirmatory diagnosis laboratory tests to for the diagnosis of the serotonin syndrome. So therefore, diagnosis is mainly clinical assessment and exclusion of other psychiatric and medical conditions, and published diagnostic criteria for may emphasize the exposure to known serotonergic agents and presence. Okay, so the treatment part is the cornerstone of treatment of treating serotonin syndrome is discontinuing all serotonergic drugs and providing appropriate supportive care. All patients with serotonin syndrome should be admitted to the hospital until their symptoms have been completely resolved. Severely ill patients require admission to an intensive care unit, and approximately 25% of the patients require endotracheal intubation and ventilator support. And most patients show dramatic improvement within 24 hours of symptom onset. Mortality varies according to the severity of the syndrome and aggressiveness of the care. Most common cause of death is severe hyperthermia. And benzodiazepines are non-specific serotonin antagonist and can be used to decrease the patient's discomfort and promote muscle relaxation. And patients with severe serotonin syndrome should be sedated and undergo neuromuscular blockade with a non-depolarizing agent and have a endotracheal tube placed, be started on mechanical ventilation and be admitted to the ICU unit. And and Cyproheptadine is an antihistamine and serotonin antagonist with anticholinergic agents. It can be used off-label for serotonin syndrome, but no, it is only available in oral form. Initial dose is 12 mg with repeated dose of 2 mg every second hourly until clinical improvement is seen. However, benefit of and indication for cyproheptadine is not known due to lack of supportive clinical evidence. Chlorpromazine is an antagonist of 5-HT2A receptors, and there are reports of successful treatment of serotonin syndrome. So, the advantage of chlorpromazine is that it is available in parenteral form, but a potential disadvantage is that it can cause hypotension. It also blocks dopamine receptors, which can promote muscle rigidity, lower seizure threshold, and exacerbate neuroleptic malignant syndrome. The use of dopamine agonist, that is bromocriptine, has no accepted role in treating patients with serotonin syndrome. Dantrolene is a non-specific muscle relaxant that is used occasionally in the management of serotonin syndrome, but clinical benefit is unproven. Muscle with patients with muscle rigidity, seizures, or hyperthermia should be monitored closely for rhabdomyolysis and or metabolic acidosis. Clinical features of serotonin syndrome usually resolve within 24 hours after inciting drug is stopped, with an exception being fluoxetine due to its long half-life and that of an active metabolite. Once a patient recovers from serotonin syndrome, avoid future exposure to serotonergic drugs. Okay, all the risk of recurrence is unknown. So this is important. The okay. So and also you can see here the in a tabular form. So first we must stop all serotonergic uh, therapy, initiate cardiopulmonary monitoring, establish peripheral IV access, obtain ECG, IV hydration, evaluate for rhabdomyolysis, external cooling measures for hyperthermia, benzodiazepines for agitation, use short-acting IV antihypertensives, that is such as nitroprusside or esmolol, for severe hypertension, and use direct-acting IV vasopressors for hypertension resistant to IV fluid resuscitation. And cyproheptadine has been suggested in the past, but clinical evidence of benefit is lacking. Thank you very much.